What do I mean when I say, or when I talk about a practical perspective for herpes keratitis? I want to tell those who aren't experienced with this kind of keratitis to a better control over this disease, which is extremely common. You certainly know that herpes come in 8 different types, but most of all, they have an incidence, a frequency, and a very high prevalence in the population. One of the most characteristic signs is the laterality, which isn't in 100% of cases present, but only 90% of cases. So you should remember that it may be bilateral. And another feature is the recurrence of the infection that may be very high, and especially that a cornea transplanted patient has a higher risk for development of this disease, 6 times as much. This is a herpes after dog. This is herpes after PKP. You may see that here we have a typical epithelial lesion. This isn't always the case, unfortunately, because we may be confronted with different kinds of lesion. This is after PKP and limbus transplantation from cadaver. These patients are exposed to frequent recurrences. But let's now turn to the aspect, the look of herpetic lesions. These are the classic ones with the primary infection and epithelial herpes recurrence. Any doctoral or postdoctoral doctor can recognize this problem, but sometimes these lesions may have an atypical lesion, and very often this may lead to incorrect or difficult diagnosis. In the past, we've been accustomed to have classification of this disease based on its morphology, but luckily enough, recently, but not too recently after all, so about 20 years ago, Dr. Holland, who is here with us, with Dr. Schwartz, have presented a new classification for the herpes virus disease and a new approach to it in terms of classification, which really was a turning point in my career. So first of all, the anatomic area that has been hit by the infection is used, but also by the identification of the pathophysiology or pathophysiological mechanism which prevails in determining the lesion. In other words, by understanding where and why the herpes manifestation is found, we may correctly classify the type, classify it properly, and therefore treating it properly, because it changes depending on this, what we have to do. So epithelial can be keratitis, can be complicated by means of following to neurotrophic keratopathy, and there might be a stromal keratitis, which considerably aggravates the neurotrophic effect, and sometimes the herpetic lesion may begin as endothelial and then be transmitted to the stroma and then result in a neurotrophic aspect. So, and this is the basis for our treatment plan, or it should be. Let's now move to the various herpetic lesions which were traditionally recognized. So the vesicles, the corneal vesicles, which is often the first sign of an herpetic lesion. And the treatment is, we all agree, is antivirals. Topical antivirals in particular. So dendritic ulcer that has to do with a dendritic lesion with no involvement of the strona. Here again, the topical antivirals should be used. What about systemic antivirals? Systemic antivirals may be a good idea, not so much when treating the herpetic lesion, but for preventing possibly the recurrence, because the antiviral herpetic lesion is not entirely, systemic is not entirely controlled or treated with a systemic treatment. But let's now move on to other forms of lesions, such as map or geographic map ulcer. Here you may see that nothing changes significantly here, but in limbal lesions, we must have a different approach. We are very close to the limbus, so the inflammatory reaction is marked, and there might develop important lesions. So I recommend here to immediately initiate systemic treatment, and as soon as the infection is brought into control, steroids should be introduced in order to prevent more severe posthumous lesions. And the neurotrophic keratopathy, we must be immediately very careful and attentive, because especially in the herpetic disease, when we have a treatment which is prolonged in time, and the damage, due to the damage by the herpes virus, as well as the suffering accompanying chronic usage of antivirals, there might be a neurotrophic disease developing, and in this case we should be extremely aggressive by fixing immediately contact lens, tarsorrhaphy, and lacrimal punctal occlusion, because otherwise this might be complicated by bacterial infection, and the sequelae might be really dramatic. In stromal forms, we have two of them essentially. The ones primarily or secondarily following neurotrophic keratopathy, and the ones following endothelitis. But we have to distinguish the form in which we have a stromal necrosis related or linked to the viral proliferation. This means that we should immediately initiate systemic antivirals, full dosage, also locally, but we should also control the infection, because the infection may favor, encourage the worsening of the symptoms. Otherwise, the stromal form, which here is shown, and here the lesion is maintained by the conflict between antigen-antibody complement cascade, which maintains a stromal involvement. And here we see the possible treatment, stromal infiltration, lipid, and all the possible treatments. No full dose is necessary here, but just one tablet of acyclovir a day is enough, plus a local steroid to keep the recurrence under control. Neglected is or underestimated is sometimes the diagnosis of endothelitis, and there are three forms: disciform, diffuse, and linear. But the first sign is usually an corneal edema, due to the fact that the endothelium affected by develops an edema, and it is only on the following days that we observe precipitates that make us suspect endothelitis. And here we see the therapy, full dose systemic antivirals and systemic steroids to prevent recurrences. let me tell you how it is important to keep the herpetic disease under control, because especially in transplanted patients might cause a rejection due to the fact that it stimulates the anti-immune activity. So this is an HSV after PKP and rejection. So the treatment here is a prophylaxis by means of systemic antivirals and local steroids to prevent and control inflammation. Let me say that we have to resort to surgery to make or to recover transparency. We should always remember that the golden standard here is the DOLC, because from the immunological viewpoint, it allows for a greater silence. So we've published this paper in 2009 on 52 eyes receiving DOLC for herpetic scar, and the triad is a systemic antiviral and locally loteprednol allowed us to control or to the relapses in all cases. And this is a very old case belonging to the same case series with a wonderful big bubble that we could perform thanks to complete stromatectomy. Results in terms of recurrences was 0 with a follow-up, 4 years of follow-up. And here I stop because the following speakers are just great and there is a lot to learn from them. Thank you.